Thank you very much, Alberto. It's really a great pleasure to be here and to present this first Hugo Schindelka lecture. There's so much I'd like to say, and we only have 45 minutes, so I'm going to focus on microbial interaction and disease control. But before I do, I'd just like to acknowledge some of the people who have inspired me and worked with me over the years. I'm only going to mention a few, but there have been many. First of all, Professor Bill Noble, who was a microbiologist at the Institute of Dermatology in London, and he inspired many people, and he was the first person I ever talked to about approaching microbiology. At that time, I was about to go to Nigeria to work in a new veterinary school on the disease dermatophilosis of cattle. This still kills millions of animals every year, severe disease. I worked there with Professor Desmond Hill and his colleagues, and it was a very interesting experience. The Civil War was still on, and we had many interesting adventures. So that was a great experience. It taught me about dermatology, but I realized that we needed to know more about the biology of skin in order to understand infectious disease. So I moved to Scotland to the Hannah Research Institute to work with Dr. David Jenkinson, one of the world's leading authorities in skin biology, and we did some really interesting work there before I moved to the Royal Veterinary College to set up a dermatology unit together with Mr. Tommy Tomsit, who was at that time the main one of the main clinical dermatologists in Britain. And we set up the group which I now, or have been leading until recently. There was a lot of fun. I did actually spend 4.5 years as a lecturer in microbiology, and my professor there was Ian Smith, a very inspiring man, and he helped me to develop some of the infectious disease models which I'll talk about today. Coming up to date, we are working in our group with Dr. or Professor Jodie Lindsay at the Institute of Infection and Immunity of St. George's Hospital. She is a world authority on the genetics of Staphylococcus aureus and other staphylococci, and we do some really interesting work with her. As I said yesterday, there are very many others whom I would like to thank. I can't thank you. You know who you are. It's been great working with you. So I'm going to talk first about antibiotic resistance and what it's driven us to, and then I'm going to talk about microbe-mediated defense, which I think is a way forward, which avoids the use of antimicrobial drugs. If we're going to develop such methods, we need to be able to model infection. So I'll talk about modeling staphylococcal infection and its control. And finally, I will dream a little and talk about restoring the microbiome. I think that Professor Hugo Schindelka would have been very pleased to be here today, because here is a picture of his pustular disease on the abdomen of a dog. He actually wrote a paper in 1888, I believe, on such a disease, and I think he'd be very encouraged to see the progress we have made. So if we go back to 2009, Professor Ian Gold wrote this paper, Antibiotic Resistance, the Perfect Storm. And what he was talking about was the end of the golden age of antibiotics. So we paid no attention to that, and we have now a review in 2014 by John Prescott, and this time he uses another climatological term, the resistance tsunami. But what's really interesting about this review is he talks about the golden age of microbiology, and that is exactly where we are. So we are losing the antibiotics, but we have huge potential to use microbiology. We can do things with microorganisms now which we would not have thought possible only a few years ago. And this has enabled us to do exciting things, and I think we're developing marvelous new methods. One of the approaches is to develop more antimicrobials. We're doing work on this at the Royal Veterinary College. You can switch off resistance genes and so on. But actually, I think we need to work with the bacteria. So most of my talk today is going to be related to harnessing defensive microbes. And this review by Ford and King, which came out in 2016, talks about harnessing the power of defensive microbes But the important point it makes is that it's referring to the evolutionary aspects. When you put bacteria in unusual circumstances and pit them against each other, there will be evolution. And we're not thinking enough about the evolutionary possibilities of the new mechanisms we develop to control infectious disease. If we think a bit more about this, the functional activity of metazoa, such as ourselves, actually depends on microbes. We couldn't survive without them. And for this reason, microbe-mediated protection is widespread in nature. We use microorganisms to help us survive. And in nature, we can see examples in vertebrates, in plants, in insects, and so on. Somebody who recognized this quite early on was a Victorian mathematician called Augustus de Morgan. He was a strange man, very idiosyncratic, and actually his colleagues didn't take him seriously. But he wrote a book, and in this book he quotes this bit of poetry, which I think he invented, and I'm just going to read it to you. Great fleas have little fleas upon their backs to bite 'em, and little fleas have lesser fleas, and so ad infinitum. And the great fleas themselves, in turn, have greater fleas to go on, while these again have greater still, and so on. And I'm sure many of you have heard that before. This is, of course, an example of hyperparasitism, which is one of the mechanisms I'm going to be talking about today. So we're now using defensive microbes in many areas, in humans, in animals, and in plants. And actually, in agriculture, there is possibly the greatest use of these at the moment. And they're also even being used now against vector-borne diseases. And as I've read about this, I've been astonished at the potential that there is there. So if we think about the microbe-mediated protection mechanisms, Ford and King have divided these into the direct methods and the host-mediated mechanisms. So if we look at the direct mechanisms, we have hyperparasitism, which I've just talked about, and we have predation. We have microorganisms that actually attack other microorganisms. A related example is in the picture on the right. So here we can actually see that we've got maggots which have been put into a wound on the knee of a man who has had chronic MRSA infection, not responding to all the conventional methods of antimicrobials for many months. He's about to risk having his leg removed. They put the maggots in. The maggots are predating on the bacteria. They're eating up the diseased tissue. This wound healed within a few weeks once the microbes were dealt with by the maggots. So there's a lot of potential here. Interference competition is another method. Here, the bacteria typically are producing substances which interfere with the pathogen. They might produce antibiotics, for instance. And then there's resource competition, where the protective microbe locks up access to a particular substance which other bacteria may require, such as iron, for instance. And then we have the host-mediated mechanisms, where the presence of our protective microbe upregulates host responses and therefore gives protection. And we can also have microbes which increase the host tolerance or the host fitness, for instance, by reducing damage caused by the pathogen or by accelerating repair. So I've already mentioned that when we use these mechanisms, there are evolutionary implications. So exploitation of these organisms could alter the host-parasite relationship. For instance, it may increase their resistance, or it may increase their virulence. And we need to understand these relationships if we're going to understand and estimate the study risks, the risks of using these organisms, and also to determine which defensive approaches and disease control agents should be used. So here we're talking about the idea of co-evolution of our organisms and the parasites. And one of the things we need to remember, and this is a big advantage, is that microbes adapt to parasites much faster, very fast, faster than the pathogen, certainly faster than the host. And this is because the microorganisms are in large population, they have rapid proliferation, and they have high rates of mutation. So co-evolution and continuing defensive activity is likely to be promoted where we have direct defensive microbe-parasite interaction. So while they're defending us, they're actually evolving in such a way as to avoid resistance. On the other hand, where they're stimulating increased host responses, then there's going to be a limited possibility for appropriate evolution because it depends on host evolution, and this is going to be much slower. So I thought I'd just spend a bit longer talking about this because it's a concept that we need to get into our minds. If we look at the way in which these microbe-mediated organisms, these defensive organisms can be, they could actually be in a state of mutualism where they are having a neutral or beneficial effect on the host, or they could evolve towards parasitism where they have an adverse effect. And of course, if we think about their existence on the skin, whenever an organism lives on a tissue or in a tissue, there is a cost to the host. This cost will drive evolutionary pressure. And if there's an overall benefit, then it will move towards mutualism. So as long as there is an overall benefit, then we are likely to preserve the microbe-mediated defense without resistance and without seeing adverse evolution towards parasitism. But if there is an excessive cost, then parasitism and increased virulence and so on may be a consequence. And we need to bear this in mind when we're developing these new methods. It's a risk which is certainly worth considering, and this was looked at by McNally and colleagues, who are mathematicians, and published a paper in 2005. You can see the title here, Microbiome Engineering Could Select for More Virulent Pathogens. This is a complex paper, so I'm just going to bring up a couple of points. They developed, one of the mathematical models they developed was of within-host pathogen versus commensal competition. And their conclusion was that microbiome manipulation may upregulate the range of pathogen virulence factors used to clear commensals, and that of course includes our potentially defensive microbes. And at the end of the paper, this is their conclusion: treatments must be designed with careful consideration of the potential evolutionary responses of target pathogens. Okay, so a warning to begin with. I want to talk now about my interest in this area. So I began to be interested over 40 years ago, and one of the things that stimulated my interest was the fact that babies in hospitals, newborn babies, were suffering from severe staphylococcal infection. And they had epidemics, and many of the babies died because the antimicrobial drugs were not available then. There were penicillins, but they often didn't work, and therefore other solutions needed to be found. And what they discovered was that a low virulent strain of Staph aureus called 502A could be inoculated either into the umbilical stump or the nasal mucosa of these babies, and it would protect them against disease. In order to establish the Staph aureus, they had to treat the babies in some way beforehand. So prior antibiotic, before these babies could acquire resistant organisms, or the use of high inocular. And here they're talking about huge numbers of organisms, 10 to the 9th colony-forming units per ml for optimal colonization. I want to quote just one work that was carried out on the results of this kind of approach, and this was published by Hook and colleagues in 1974. And they inoculated 654 newborn babies with 502A. 606 remained healthy, and 38, that is 5.9%, developed infection with the 502A. Wow. Nowadays, would we consider using a treatment which is likely to induce infection in about 6% of the babies? I think we would find it rather difficult. What these authors also noticed was that the 502A transferred to other babies. So the babies they didn't inoculate, 444 of them were spontaneously colonized, and those still developed 0.5% of infections with 502A. Again, you think, wow, how could they go on doing that? And actually, there were other studies where much higher proportions of babies became infected. Their conclusion was the benefits of Staph aureus 502A programs far outweigh their hazards. So in the non-antibiotic era, that's what had to happen. You had to take risks. And we are moving into another non- or useless antibiotic era. I hope we don't ever get to that point. And that's why we need to develop alternative methods. So I talked about the need for developing staphylococcal skin infection models. We need these to study the pathogenesis of infection, modes of therapy, and also microbial interactions in vivo after we've demonstrated them in studies in vitro. People have tried this since the 1950s. They've tried it in all sorts of animals, humans, rodents, dogs, and so on, and it has been very difficult. Quite severe damage has needed to be caused by scarification or occlusion or injection or inoculation into tissues such as the mammary gland or the vagina in order to establish these infections. And generally, the infections lead to recovery, and so they're very difficult to manage and difficult to interpret in terms of models for diseases or methods which we wish to study. We became aware of this at the Royal Veterinary College, and we thought that the pig disease, exudative epidermitis, could be a good model because it's caused by a pathogenic staphylococcus, and the disease is very like staphylococcal scalded skin syndrome of babies. So a very close parallel to Staph aureus. Both diseases involve an exfoliative toxin which actually causes the disease. So nice model. We were also lucky that at the Royal Veterinary College, Professor Trexler, who developed the first isolators for isolating or studying disease in people and in animals, had come to the Royal Veterinary College and developed a system where we could produce germ-free pigs. So we used these germ-free or notobiotic pigs for our studies. So in this method, you take sows, you then deliver the piglets by cesarean section into isolators in a germ-free way. The isolators are transferred to this big experimental isolator, which you can see in the image here, and then they are inserted there, and we can carry out all of the procedures we want to with the gloves. You can see this guy here using gloves, and essentially we can sample them and we can inoculate them. And in the studies I will describe, our inoculation procedure involves only rubbing the swab lightly on the skin, so nothing severe. So the first study we wanted to carry out was to see whether Staphylococcus would be suitable. These notobiotic piglets have high susceptibility, but we didn't know what would happen. So we worked with piglets in pairs in separate isolators. They were inoculated at 14 days of age. We used 3 Staphylococcus strains from exudative epidermitis, P411, P119, and SK170. And because we didn't know how pathogenic the coagulase-negative staphylococci might be in these piglets, we also inoculated with Staphylococcus warneri and Staphylococcus epidermidis. And then we observed the clinical status and the bacterial populations until the piglets were 27 years old. And here on the right, you can see a piglet with this disease, and it's a nasty disease. This is the subacute form. It can be much worse than this. So we found that all of the strains of Staphylococcus and the coagulase negatives colonized the skin and spread into their environment, but the Staph warneri and Staph epidermidis stabilized and caused no lesions. The Staphylococcus P119 and P411 caused exudative epidermitis. We found that lesion onset occurred when counts reached log 6 colony-forming units per swab, and the disease severity was proportional to the population size. So that seemed like a good model. What was really interesting was that SK170 caused no lesions at all. Here we can see the counts. You can see on the x-axis we have a red arrow here where we had inoculation at day 14, and that is the age of the piglets. P119 is in dark blue. You can see the population rose rapidly to over log 7 when it stabilized. P411 seemed to rise more slowly, but ended up around log 7. But SK170 never rose above log 4. So there was a distinct difference here. So what we wanted to do next was to see whether we could use the avirulent strain to inhibit the virulent strain, as had been done in humans with 502A. So we first of all inoculated piglets with the virulent 411, P411 alone, and lesions appeared after 4 days when the mean colony-forming units per centimeter squared exceeded log 5. And they became severe and extensive after 8 days. Here you can see a graph showing the counts. You can see that we've inoculated P411 at day 14, and then you can see the counts going up from log 5 to log 8 and causing severe disease. So we then inoculated SK170 2 days earlier, so this was then inoculated here at day 12, and you can see that the counts of SK170 rapidly stabilized around log 4 and stayed at that level, whereas P411 never exceeded log 3. So suppression of the P411 meant that the animals that received first the SK170 remained healthy despite having the pathogenic Staphylococcus. So we were absolutely delighted. In those days, we didn't understand quorum sensing. Quorum sensing is a process whereby bacteria communicate together, they exchange messages, and when populations reach a high level, appropriate to cause disease, they will all start producing toxins. Probably what has happened here is that P411 never reached a level where it could begin toxin formation. So it remained a harmless organism living on the skin. Well, we didn't want necessarily to use an avirulent Staphylococcus for control of this disease, because avirulent organisms can revert to virulence. So what we did was to study strains of other bacteria from healthy piglets to see if we could find inhibitor producers which we could use to prevent the disease. So you can see we tested 500 strains. We then selected a few which were potent antagonists, and we tested them against P411 in notobiotic piglets. And what we found was that exudative epidermitis occurred in all of the piglets that were inoculated with Staphylococcus. But the Staphylococcus populations were lower in the presence of the inhibitors. And interestingly, piglets which we pre-colonized with an inhibitory Staph epidermidis, together with non-inhibitory Staph hominis and Staph warneri, had significantly lower colonization and much milder disease. So when we introduce more of, if you like, a flora, a microbiome, rather than just a single organism, there is more effect. And clearly, when we bring organisms together and they live in harmony, we can have more effects. And this is something we need to study more and more. So, whoa, what's happened? Yeah, so here we have a graph showing the experiment where we inoculated with the coagulase-negative staphylococci that were non-inhibitory plus our inhibitory one. And the green line shows the counts for this group of organisms, which reached around log 7, roughly. Dark blue shows P411 alone. We had two piglets, and then one died. So this was severe disease when this organism was there by itself. And when it was there with the other organisms, you can see the counts remained lower. They did eventually get up to around log 6, but we had much milder disease. And if we had persisted, we might have found ways of actually preventing the disease. But actually, we wanted to move on to see whether we could find a way of dealing with canine pyoderma. If we're going to treat canine pyoderma with this way, we would need to find low virulence antagonistic strains. We already knew the differences in virulence amongst Staph intermedius. By the way, when I say Staph intermedius, it's what we call Staph pseudointermedius these days. We knew that there were differences in virulence, so we were confident that we could find more and less virulent strains, but we needed to have evidence of antagonism. We also needed to find appropriate methods of administration, but we thought we might be able to use methods equivalent to those which had been used for Staph aureus 502A, particularly inoculating in neonatal animals prior to establishment of their normal microbiota, or following antimicrobial therapy to decrease the normal flora, or by the use of very high density inoculant. And this is one of the first studies we did. And what we did was to isolate a total of 453 isolates from 57 dogs, of which 15 had pyoderma. and we evaluated their activity in vitro against Staph intermedius. These organisms were Staphylococci and micrococci, and as you can see, we had 80 micrococci, 191 coagulase negatives, 182 coagulase positives. Big differences in the proportion of those which were inhibitory to Staph intermedius. So 8.24% of the coagulase positives were resistant. And this is not surprising, because organisms produce inhibitors to organisms that are closely related to them because they're going to occupy the same space and want to do the same things. And most of these isolates came from the pyoderma animals because that's where the conflict would be greatest. That's where the evolution of inhibitory organisms is most likely to occur. Well, the next stage was to see whether we could actually eliminate the flora from dogs to prepare them for inoculation of our inhibitory organisms. And what we did was to use 1% fusidic acid. This was applied twice daily for 7 days to the eyes, nostril, anus, and vulva of 6 beagle bitches. In fact, only 5 completed the study, but there were 6 untreated controls. And we counted the cutaneous and mucosal populations before and 2, 4, 8, 14, and 21 days after treatment. What we found on the skin was that counts reduced at 2 days post-treatment and then returned to pre-treatment levels after 7 days. On the mucosae, there were reduced counts and frequency of isolation 2 days after the end of therapy, and they remained low for the rest of the study. Here you can see a chart showing one of the pieces of data here. So these are the mean counts from the mucosal sites. Green shows the controls, red shows the treated animals. Here is the treatment period of 7 days. And if you look at the first measurement at 2 days after the end of treatment, you can see that the counts have dramatically reduced. In fact, when we looked at frequency, all of these organisms came from only one single site on one animal. So, in fact, for most of the mucosae, nearly all of the mucosae, we actually had eliminated the Staph intermedius. And then, afterwards, the organism numbers increased, but they remained low for the rest of the study. So we showed that treatment of the mucosae is effective and also reduces skin population, and this emphasizes the importance of mucosae as carriage sites. It also shows that carriage can be reduced significantly by topical treatment. Well, this is even more important now for all sorts of reasons, because we have multi-resistant Staph pseudointermedius, and we are currently studying at the Royal Veterinary College more detailed mechanisms for decolonizing or removing the Staph pseudointermedius flora in dogs. Okay, so we also wanted to know, how did these animals come to colonize, and would we be able to interfere with this? So we studied this in Cavalier King Charles Spaniels, 5 bitches and their 18 puppies in a home environment, and we looked at them prepartum and for 8 weeks after whelping. We showed that carriage was well established on mucosal and skin sites by 8 hours. And here you can see 3 pieces of data, and we can see that the nasal mucosae had 83% colonization carriage, oral mucosa 73, abdominal skin 73% carriage. So establishment very early on all of those sites. Interestingly, the level of colonization in the bitches seemed to influence colonization of the puppies. And we also had other data on colonization which supports that. So that seems to be an important aspect, and it's not at all surprising. So we then wanted to see, well, how long would these organisms persist if you inoculate Staphylococci, Staph pseudointermedius onto dogs? How long will those strains persist? So we again studied Cavalier King Charles Spaniels, 3 bitches and their puppies in a home environment, but this time after whelping and for up to 15 weeks. And what we found was that there were 240 cutaneous and mucosal Staph intermedius isolates, which could be genotyped and shown to be different by RAPD-PCR. Actually, there were 17 different genotypes identified. 1 or 2 of these were dominant in each of the bitches and their puppies. The rest of these genotypes, the rest of these 17 genotypes, were isolated only once or twice. So the Staph intermedius flora of each bitch mainly consisted of 1 or 2 dominating and persistent clones, which were then transferred to the puppies at birth. So these clones persisted despite transient carriage of many other strains. Actually, this is not so new. We know that in humans, a similar thing happens. When a mother feeds her baby, the babies acquire the flora from her mother's breasts, and 1 or 2 dominant clones will tend to persist for the lifetime of the child or that individual. What it does is to offer us potential, though, for inoculation of a virulent strains, which might then provide microbe-mediated defense on a long-term basis. Well, coming up to date now, we are actually using more sophisticated mechanisms to study how these organisms can evolve on the skin. And again, we're using our notobiotic model. And this paper that I want to quote to you was published in 2014. And it was an experimental evolution study. And what we did was to co-colonize notobiotic piglets with human-associated and pig-associated Staph aureus CC398. CC398 is a Staph aureus which emerged in pigs, rapidly became common in livestock, and is now becoming a problem in people. So we had a human-associated and a pig-associated, genetically different, behaviorally different, and we put them onto our notobiotic piglets at the same time. And what we were able to show was that horizontal gene transfer between the clones occurred within 4 hours and occurred at very high frequency. So almost immediately, evolution was beginning. But the 2 clones, the human and pig-associated clones, coexisted, and they diversified within their own clones rather than a single variant dominating. And what was even more interesting was that each piglet carried unique population variants. So each one, even though they were very close together in this isolator, was able to maintain its own unique microbiome, if you like, suggesting that limited transmission of bacteria occurs once piglets are colonized. So, could microbe-mediated defense work on skin? Let's look at some of the human data to begin with. I'm going to quote some data here on probiotics. I know that there will be a state-of-the-art lecture later on in the meeting, so you'll learn a lot more about it, but I'm just looking here at 2 reviews on infection control using microbe-mediated defense, and this is 2 reviews, one by Sikorska and Smoragiewicz of 2013, and a very recent one which dealt with Pseudomonas by Chatterjee in 2016. Essentially what they say is that if we put aside the in vitro study, there are only a few small human trials using oral or topical probiotics. Of course, when you give a probiotic orally, it's topical in the gut. But when we say topical here, I'm talking about on skin or infected tissue. So only a few trials and really not very much positive result. And they say much more work needs to be done. And then, of course, atopic dermatitis has also been approached in the human field using probiotics. And a review which was published very recently this year by Rather and colleagues, and they conclude that strong evidence for oral probiotic use is lacking. So what are probiotics? And I think that the definition has been slightly modifying. We used to think of it as being some kind of rather sophisticated yogurt, but now we're using it much more broadly, and in this lecture, I'm really thinking of it as microorganisms which we may apply to the skin in particular ways. The definition from World Health Organization and FAO is, as I've given you here, live microorganisms which confer a health benefit on the host. And I think that's actually quite a nice definition. So what about in animals? Well, there is evidence on the use of oral probiotics in dogs, particularly in atopic dermatitis, and Marzella and colleagues carried out a study a few years ago, and then they looked at it 2 years later, and the publication of that second study was in 2012, and this was on early exposure to probiotics in a canine model of atopic dermatitis, and they showed that there were long-term clinical and immunological effects. But in their discussion, they say, actually, we need to do more work on this, and we need to see if it's appropriate in spontaneous cases of atopic dermatitis. Such a paper was actually published in 2015 by Kim and colleagues from Korea. This was a double-blind, placebo-controlled trial of a probiotic strain, Lactobacillus sakii, for prevention of canine atopic dermatitis. They had 42 dogs with spontaneous disease, and they showed that they could establish reduced clinical signs as measured by CADESI and reduced pruritus scores. Very encouraging, just a single study, and when you look at the pictures, you can see severely affected animals and then much less affected animals, but clearly still with significant clinical signs. So this is a beginning, it's really interesting, but clearly more work is required here as well. So I really want to dream a little now. Could topical probiotic or microbiome supplementation work in atopic dermatitis? We know that in gastrointestinal disease, this has been used for quite some time. And we've got used to the idea of not using the word cappuccino, but using the word crappuccino for transferring gut contents from one person to another or from one animal to another. And I know that Dr. Marks, Professor Marks, is going to talk about this later on in the week, but briefly, an increasing range of human diseases seem to respond. And some of these diseases are not just gut diseases, some of them are diseases affecting other organs of the body. So there is, I think, a lot of potential for the concept. And if we think of the gut as being another epithelial tissue, another surface, the question I really want to ask is, could we possibly use this in animals? And might it work in atopic dermatitis? Now, Dr. Rodriguez-Hoffman will be talking later on in this session, this meeting as well, about the work they've done in Texas on the skin microbiome. But I just want to quote this paper, which they published in 2014, on the skin microbiome in healthy and allergic dogs. They described this as a preliminary study, although it was a very thorough study, and they showed that the skin of allergic dogs has a lower species richness compared with that of healthy dogs. So when this disease occurs, the microbiome changes. And is it possible, really, that in fact, as in the gut, when you replace a diseased microbiome with a healthy microbiome, you can actually control the disease? And maybe it'll work. There are lots of parallels between the gut and the skin. So my dream is, might suppression of pathogenic Staphylococci and replacement of the cutaneous populations have a dual effect and reset the allergic status of the skin sufficient to control canine pyoderma? I'm sure that working this out will take a long time. But we're going to meet again in 4 years in Sydney. I hope we're all going to be there. I wonder if then we won't be talking about crappuccino, but cuticino. Wouldn't that be nice? So I thought I'd end up by talking briefly about a man whom I greatly admire, Sir Alexander Fleming, basically the man who brought about the antibiotic revolution. He discovered penicillin, and he was already at that time concerned about evolution within the microbiome, although he wouldn't have used that terminology at all. In his Nobel Prize-winning speech, this is what he said: "The time may come when penicillin can be bought by anyone in the shops. Then there is the danger that the ignorant man may easily underdose himself and, by exposing his microbes to non-lethal quantities of the drug, make them resistant." Well, we went big time on this, didn't we? It wasn't just the man in the street. We all did it in the human field, in the companion animal field, in agriculture, and we got rid of the we got rid of the antibiotic use now. Tremendous, tremendous problem. He foresaw that. Now we have a new opportunity. In the golden age of microbiology, we can change things. And I think this area of microbe-mediated defense is hugely, potentially possible to control these diseases. There is a great potential there. So what I would like us to do is to heed what Sir Alexander Fleming said, as quoted by the mathematicians. So this is what McNally and colleagues said. You remember, treatments must be designed with careful consideration of the potential evolutionary responses of target pathogens. Let's do that. And I'm sure that Sir Alexander, along with Hugo Schindelka, will be up there, and they'll be nodding their heads. Thank you very much.